Medication can manipulate and moderate things. The question is what happens when you stop. So these new GLP-1 drugs are no different. And so it was really important at the end of last year. I mean, one of the most important pieces of evidence we have on what happens to you after you remove these GLP-1/GIP agonists like Mounjaro. It comes from a large phase 3 clinical trial called SURMOUNT-4. So essentially what they did was they followed, it was about 783 patients, and they followed them after they'd been put onto Mounjaro. And then after an appropriate amount of time, they basically randomized into two groups where they either continued with Mounjaro or they were switched to a placebo injection. Now, what was striking was that most people who were switched to placebo regained a very large proportion of their weight that they had lost. Several of the benefits that had happened while they were taking Mounjaro, such as improvement in their blood pressure and glucose, tended to reverse. So this is meaningful because it tells us that the body's regulatory biology often reasserts itself once the drug is removed. I think this is true of many, many drugs that people actually use long term.
Welcome to the Metabolic Balance Stories podcast. This is where we share real stories and insights to help you on your journey to optimal health with personalized nutrition and metabolic balance. I'm Sherry Wills, I'm your host, and I'm delighted to welcome my guest today, who has spent over 38 years helping people make sense of their health with his in-depth, integrated, and systems-based approach. Mr. Gerry Gajadharsingh is a highly experienced osteopath and functional medicine practitioner and is the founder of the Health Equation, with clinics on Harley Street in London and in Wiltshire, the UK. He has a wealth of experience and expertise and is a highly sought-after leader, speaker, and international lecturer within the osteopathic community and osteopathic care. His knowledge of metabolic balance is also incredible, as he is not only supports his clients with metabolic balance, but has also been an excellent trainer of our method within the UK for over 15 years up until last year. And I should confess, he actually is the person that trained me. So it is so wonderful to have you on the show, Gerry. It feels a little bit like that sort of full circle moment. I am really delighted that we're going to be diving into one of the hottest topics in health right now, which is the GLP-1 medications like Ozempic and Mounjaro, and specifically the impact that these medications have on the body and what actually happens when people stop taking them and what needs to be in place to make sure that results last. It's such an important topic, but a big welcome to you, Gerry. Thank you so much for joining me.
Cherry, thank you so much for inviting me to join you and, of course, for the very kind introduction. As you say, I've been in clinical practice for around 4 decades, and although I qualified as an osteopath, and in my opinion, was the original functional medicine philosophy.
Yeah, I can see that. Mm-hmm.
And that, of course, naturally led me to more integrated functional medical approach. Both in diagnostics and in the management and treatment of patients. Nutrition has always been, quite a large part of my practice, partly because I studied it at undergraduate level as an osteopath, but I later found it so interesting. I pursued it at postgraduate level, including what we call applied pathophysiology and nutrition. In terms of your sort of specific question, because I lecture a lot, and one of the countries I lecture a lot in is Germany. And it was actually through one of my German colleagues that I first heard about metabolic balance. And I decided to sort of undertake the program myself and found it really intellectually fascinating, as well as being clinically quite relevant in terms of what I was doing it for.
When was this? This must have been at the very early origins of the program.
It was about 2009, if I remember correctly.
Yeah.
And, after actually having done the program, I decided, this is something I think I'd like to sort of train in myself. And so I did have the privilege of being taught by the founder, Dr. Wolf Funfack. What struck me about Wolf is, as you know, nutrition in conventional medicine or conventional medical education often receives minimal attention.
It definitely used to. I mean, like, it definitely was like that for a number of years. I mean, it still is now. But yeah, it was that back then. It must have been very much hardly ever any mention.
I think, obviously, doctors and consultants are, I think, talking more about nutrition, partly because there's much more research about it. But in balance, because the whole system has been focused on pathology and not really about sort of manipulating function. But I think the point was, Wolf was obviously different. And, when he developed metabolic balance, I think what struck me was it wasn't a diet. It really was developing something to change metabolic architecture.
Yes, yeah, that's a great term, metabolic architecture. Absolutely. And so what? How did you become a trainer in MB?
As you know, the person who used to run MB UK, the lovely Gloria Parfit, Gloria was an amazing character. She wanted people who actually were both clinicians and understood nutrition a little bit more. So she very bravely nominated myself and my co-lecturer, Anthony Haynes, who, as you know, is a wonderful nutritionist. And we were both invited over to train in Germany. So Anthony and I used to do the MB Coaches Weekend in the UK between the two of us.
Yeah, I remember because I was in that audience, but I'm pretty sure you don't remember me because I was just a little person in the audience. A little person in the audience, just trying to soak it all in at that time.
We're always going to remember you, Cherry. Never fear about that. But
Yeah.
if I sort of go on a little bit, I mean, again, what sort of struck me about this metabolic architecture really was, you're looking at blood chemistry to guide your food choices. And we know that protein prioritization is really key, and insulin regulation, and therefore glucose stability. And so what I sort of found was that, yes, of course, it produces weight loss. But my interest has never really been cosmetic weight loss. For me, it's always been about metabolic physiology.
Yeah, I'm exactly the same. Yeah, totally.
And of course, over the years, we've seen low fat and low carb and detoxes and intermittent fasting and microbiome testing. And now, of course, what we're talking about are what we call GLP-1 and GIP medications. And one of the drugs we're going to talk about later on this morning is Mounjaro, otherwise known as tirzepatide, which is both a GLP-1 and GIP receptor agonist. So sometimes in a conversation, we may just be using the term GLP-1, but actually when we look at the research later, it's actually a drug which is both GLP-1 and GIP.
Thank you. I mean, it's so important to actually help people understand what these drugs are and how they manifest in the body. Coming back to sort of the focus of metabolic balance and your early point, start with MB, was there a particular client that you could think of that really made you stop and think this actually is having a really profound effect on results?
I think there are numerous patients, but I think one that really strikes and stands out is actually a wonderful lady who was in her mid-60s who came to see me with sort of multiple issues. She was overweight. She had a BMI of about 30. She had been diagnosed with type 2 diabetes and had been on a diabetic drug called metformin for about 12 years, but it wasn't really controlling her blood sugar terribly well. She'd also had another condition called polymyalgia rheumatica, which is rheumatological disease, and she was taking oral steroids in the form of prednisolone. She'd also been diagnosed with non-alcoholic fatty liver disease, and she had raised cholesterol, and a GP was basically starting to think about putting her on statins. So when we look at all these things, she basically had sort of full metabolic syndrome. When we organized the metabolic balance program, one of the key and I think unique selling points of metabolic balance is really the utilization of the blood test parameters into how does the individualized plan, how is that generated? For this lady, it wasn't really just cosmetic weight gain. This was systemic metabolic dysfunction. And so what we did was we intervened with our 6-month program, and possibly a little bit unusual because I know for lots of coaches, they offer 3-month programs. I've always felt actually that for me, for sustained metabolics of imprinting, I felt that for my patients who tend to be very complex medical patients, I needed to really provide a minimum of a 6-month program. So this is what we provide for this particular lady. And as you know, it's comprised of 3 meals a day, no grazing. And that's a key point I think we need to keep on coming back to. Prioritizing proteins at each meal. And because she was diabetic, we actually also had glucose monitoring as well, which I think is very important. You know, when coaches are looking after diabetic patients, particularly, type 1s actually, but type 2s I often monitor as well, particularly if they're on diabetic medication, you need to make sure that they are managing their glucose, because actually as you manipulate their structured meal plans, you very often need to have a down regulation of some of their medication, and we tend to do that with the patient's GP. The other things I think which are relevant is resistance training. We like movement, and so obviously as part of the program, getting patients to get involved in gentle muscle resistance work, which is important. And for me, one of the things I think I always do with all my patients is I look at their breathing.
Yes, that good alkalinity. Yeah, it's so important. Yeah. So how did this lady go?
So within 6 months, her HbA1c dropped from 63 to 40, which is in the normal range. Her fasting glucose dropped from 9.1 to 5.6. That's in the normal range. Her LDL, bad cholesterol, dropped 4.7 to 3. That's in the normal range. Her ALT, liver function marker, dropped from 68 to 23. That's in the normal range. And if people wanted to know, she lost 18 kilograms, which was 21% of her body weight.
Yeah, she must have been so thrilled.
She was, but again, it's interesting because these new drugs, they are saying on average people lose 20% of their body weight. Well, actually, here we have an example of a woman doing a proper structured metabolic program like Metabolic Balance, also losing 21%. So,
And yeah, absolutely. Yeah.
the reasons why I chose this particular example, so we can sort of compare like with like, really. And I think what was really, really, really important, she was then able to stop her metformin. So the GP was happy that she was then no longer needing her diabetic drug. Her steroids were reduced and her statins were no longer required. So I suppose the takeaway with this wasn't appetite suppression. This was metabolic correction. And that's an important sort of phrase to take away.
And I think this is just a wonderful example of where, as a clinician, when you're really seeing that kind of change, it is something you say, why, that metabolic balance is a really important program to, do the training for and continue to use in practice. So if we kind of come back to sort of the GLP-1s then, which is what we are really wanting to talk about today. There's a lot of mixed, they're incredibly popular right now. They are in the public eye, very much so. Many, many headlines talking about them. There's headlines talking about the negative side effects, but we know that they're also doing some good stuff as well. They have been pretty well researched. And where are you seeing them that they actually are? What are they doing well at the moment that we should not completely poo-poo them, sort of thing?
Yeah, not at all. I mean, because I live in an integrated medical world, and a lot of my patients come from GPs and consultants, I absolutely see, the value of medical diagnostics and medications and surgery. So there's no doubt that, these new drugs, GLP-1s like semaglutide and dual GLP-1s and GIPs like tirzepatide, are absolutely powerful tools. I mean, they definitely, in many, many people, reduce appetite. They also reduce food noise, and they improve glycaemic control. And so for many, many patients, especially those with sort of insulin resistance, they are definitely transformative. So the question really isn't whether they work, because they do work for most people. The question is, what happens when they stop?
It's a vital question to ask, because it is something you can't expect somebody to take them long term. I actually read a blog piece that you have wrote about what happens when people stop these, and you talk. There's a Surmount 4 trial. Could you just talk us through what that sort of showed, that trial?
Yeah, so just a bit about medication. I mean, it's if for example you take high blood pressure, um, when a lot of people reach a certain age and they're diagnosed with hypertension or high blood pressure, it's very common for the GP to prescribe some sort of medication. Now, the problem is, for a lot of people, they will then be taking those drugs for the rest of their life, because if they stop them, the high pressure comes back again. Now, what we do know is medication can manipulate and moderate things. The question is what happens when you stop. So these new GLP-1 drugs are no different. And so it was really important at the end of last year. I mean, one of the most important pieces of evidence we have on what happens to you after you remove these GLP-1/GIP agonists like Mounjaro. It comes from a large phase 3 clinical trial, rightly, as you say, called Surmount 4. So what is Surmount 4? So Surmount 4 was what we call a withdrawal study with a post hoc analysis, and it was published at the JAMA, which is the Journal of the American Medical Association. So it's a very well-respected journal. It was published in late 2025, so not so long ago. And the lead authors, I should mention, Deborah B. Horn and her colleagues. So essentially what they did was it was about 783 patients, and they followed them after they'd been put onto Mounjaro. And then after an appropriate amount of time, they basically randomized into two groups where they either continued with Mounjaro or they were switched to a placebo injection. And I think it was about 670 patients continued into basically the withdrawal part of the study. Now, what was striking was that most people who were switched to placebo regained a very large proportion of their weight that they had lost. Obviously quite sad for them, but also from a metabolic perspective, several of the cardiometabolic benefits that had happened while they were taking Mounjaro, such as improvement in their blood pressure and glucose, tended to reverse. So this is meaningful because it tells us that the body's regulatory biology often reasserts itself once the drug is removed. I think this is true of many, many drugs that people actually use long term. And so when we're talking about these particular drugs, I mean, that has profound implications on how we think about long-term weight and metabolic management. Because the question to ask is, these are expensive drugs, and are people meant to be taking them for the rest of their lives? Considering that we actually don't really know what the long-term side effects of these things might be. But this particular trial, at least, is starting to make us ask questions.
My concern always with with taking these long term or even short term, if you're not eating, because they stop the appetite, they reduce the food noise, they limit the hunger, and then people aren't going to be eating good food because their nutrition will significantly drop, and that long term significantly worries me.
Yeah, I can completely agree.
Yeah. So If we talk about the set point, the metabolic set point, because ideally, whenever we want to change any weight, we want to reduce down the set point. Now, obviously, first of all, if you could just describe for everybody what the set point means, and really why is it important to change the set point?
I suppose one analogy might be sort of to think of metabolism like a thermostat. And so if your body has adapted to carrying excess weight, inflammation, insulin resistance, and that becomes its defended norm, it's like it's hardwired. Another analogy might be someone's breathing pattern. I look at a lot of people's breathing patterns, and a lot of people have a very fast breathing rate. They don't even know it because it's their norm. And so it's very common that within our bodies, for a variety of reasons, it might be genetic, it might be environmental, it might be ongoing habitual things like what we're used to, what we like eating, all the rest of it. But there's definitely something called a set point. And so what happens when you lose weight rapidly, hunger hormones increase, satiety hormones fall, and energy expenditure drops. Now, that's not weakness. That's essentially survival biology. So the real question becomes actually, can we recalibrate the system? Are we able to reset this set point? Now, it's quite clear with the SURMOUNT 4 trial that it's unfortunate that maybe just going down the drug route does not reset the set point, because if it did, these patients, their markers such as blood glucose and blood pressure and their weight would not have rebounded. So there must be something else that we need to do.
Can you share, is there evidence that it can genuinely be shifted? And what is it that needs to happen?
As far as I'm aware, I don't think we have any long-term definitive proof of permanent set point resetting. But clinically, we see that when insulin sensitivity improves and inflammatory tone reduces, and muscle mass increases and meal structures stabilize, hunger signaling changes. So that suggests regulatory recalibration is possible. It may well be that, hopefully in a few years' time, some bright scientist somewhere is going to be proving that you can reset the set point. But at the moment, we think we can, but I'm not sure if there's much evidence out there to say we definitely can.
I mean, I certainly see from my own clinical practice that when we really do get somebody really nicely educated with metabolic balance and we get that change in that nice gradual fashion, it's perfectly possible to reduce the set point from my experience.
Absolutely right. And lots of us in clinical practice have what we call anecdotal evidence. Unfortunately, in medicine, definitive proof is not anecdotal evidence. So
Yeah, no. So thousands of clients aren't enough. But
not enough, unfortunately.
what do you think about using metabolic balance to help people transition off the GLP-1s?
I suppose we can take this in sort of two stages. So if you're thinking about when someone's actually coming off one of these drugs, we know that there are going to be sort of several predictable physiological pressures which sort of start to emerge. So we know that, for example, appetite returns, gastric emptying normalizes, insulin secretion patterns shift, ghrelin and other sort of hunger signaling hormones rebound, resting metabolic rate may be reduced due to prior weight loss. And of course, one of the things you talked about is lean muscle mass may be suboptimal. So we know that the patients, when they're coming off these things, these are the sort of things that are going to be sort of, happening. Now, we know they're powerful because they externally amplify satiety or fullness signaling and slow gastric emptying, but they do not necessarily correct the underlying metabolic dysregulation, as has been shown by the SURMOUNT 4 trial. So the question is, I think most metabolic balance coaches would agree that metabolic balance works at a different layer. Okay, so what layer is that working? So at a physiological level, what MB is trying to do is obviously to improve insulin sensitivity. And how does it do that? It does that because it had structured micronutrient timing, and control carbohydrate load, which basically reduces postprandial insulin spikes.
So just to be clear for anybody listening, this is after the meal. Postprandial is after you've eaten. Yeah.
Sorry, yes. So postprandial means after meal. So the way chemistry works is whenever you eat something, essentially glucose hits your system and insulin is released by the pancreas in response to trying to lower blood glucose. So insulin is a key hormone. The question is that people, and this is where the eating between meals and grazing comes in, which has been endemic in modern society for at least 30 years, is you people are just mucking around with their insulin levels. And one of the key benefits of metabolic balance, particularly the 5 hours in between meals, is basically lowering this hyperinsulin response and so improving metabolic flexibility. And as a consequence of that, we then start to see stabilization in what we call glycaemic or sugar control. And that basically starts to then impact on these hunger hormones, and therefore the patient becomes less hungry. And now we all know, obviously, in the early stages of metabolic balance, it's very challenging for patients who've been constantly snacking and eating between meals to start even moving to sort of breakfast, no eating, lunch, no eating, dinner. But we do know that within a couple of weeks, most patients, I mean, the vast majority of patients, are able and start to enjoy that way of eating. So glycemic control is key. We also know that essentially what we're doing is we're sort of rebuilding endogenous appetite control. So instead of relying on the drugs to control appetite, by defining the meal timing, by defining protein prioritization, which is one of the keys of the principles of metabolic balance, and then these structured intervals between meals, essentially what we're doing is we're recalibrating leptin and ghrelin, which are these hormone signalers, rather than the drugs overriding it. And I think that's another key thing that metabolic balance can sort of come in to do. You mentioned earlier on about this issue of these drugs. So, we know one of the key concerns we have is these drugs are in a lot of people causing what we call sarcopenia. So essentially mean or lean muscle is being basically used as an energy source, primarily because these patients are probably very calorifically controlled because of the drugs. And so I've certainly seen patients where, for example, I've had to do a scan of their back and it's come up that actually I now need to do a DEXA scan because there's a suspicion of bone density changes. And, all these things are complications. But the key thing, again, about metabolic balance, because they prioritize adequate protein at each meal, and that's quite a key thing, and resistance exercise integration and structured metabolic support. Basically, this sort of protects the sort of the lean or the muscle mass within the patient. And another key thing, partly because of a lot of the complex medical things I see, and most pathology, by the way, is driven by inflammation, metabolic balance reduces inflammatory load. And so we know that adipose or fatty tissue drives sort of insulin resistance. And insulin per se tends to activate other what we call inflammatory cytokines. So elevated insulin, activates other inflammatory chemicals within the body. So metabolic balance actually is a very good way of lowering inflammation. And I often call metabolic balance the best anti-inflammatory eating program I know.
Sorry, I just would add to that, because everything you just said as well, the sarcopenia, so that muscle wasting, that inflammation, or the inflammaging that actually happens from that chronic low level, that's all seriously aging on the body as well, isn't it? I mean, it's accelerating the aging process.
They may well be losing a shed load of weight, but I'm sure they're going to run into, well, that's not a great look.
No, it's the muscle loss.
Exactly.
So, I think, coming back to the sort of the question about MB is we really can potentially reduce this down, can't we? This or support somebody with their food.
One of the things that confused me right in the beginning was the simplistic thought was these drugs are basically just activating insulin within the body. Yet one of the principles of metabolic balance was to be reducing the level of insulin. So I always found that in the beginning quite confusing for me because I like to understand mechanisms. But I think there is a nuance in the understanding of the mechanism. And essentially what these drugs seem to be doing is whilst initially increasing insulin, it reduces the overall need for insulin, which is sort of in a way fits into some of the mechanistic principles behind metabolic balance. So that was an important thing to sort of get out, really.
Yeah, that's interesting. Yeah, yeah.
But in terms of your question, so when I look at, what might a typical patient journey look like if they're trying to come off GLP-1 medication. So in reality, I suspect there are probably three types of patients. So those who want to come off GLP-1s due to either the cost or side effects, that's one group of patients. We might find those who have reached their target weight, but they fear rebound, as in they're putting back on their weight, or those who feel metabolically fragile without the drug. And I think it's very important to not underestimate the psychological impact of when you're on a drug and it's doing something. The fear of coming off is enormous, absolutely enormous.
Absolutely. Yeah.
So if we've got those three sort of categories of patients, what I would do, I'd start off obviously with a metabolic assessment on the blood results that we request for metabolic balance. I'll often do what we call a functional blood analysis. So, when patients get blood test results, they very often don't even know what they mean. They just sent these results, for example, by their doctors, and the patient doesn't really know what's going on. And I think helping the patient understand how the physiology is working is a very good motivator for understanding why something like metabolic balance, may well be helpful. And of course, in order to generate a metabolic balance plan, we have to have these blood tests done anyway to use these markers. We need to look at their stress and sleep patterns, which are key. And as you know, it's very, I think, fascinating for patients to know you lose most weight when you go to sleep. And again, there are many metabolic reasons for that, and very often in an early stage metabolic balance plan, we are asking patients to not overdo exercise, which again, you're challenging people's beliefs. People actually believe by going out and doing a shed load of cardio, you're going to lose a load of weight. And we now know scientifically that's really not very true. And so sleep is a critical thing. So assessing the patient's sleep pattern. And I think we also need to know really whether insulin resistance is still likely, because if they stop the GLP-1 abruptly without repairing the metabolism, there's a very, very high risk for rebound, as in weight gain or change of their cardiometabolic risk factors. Okay. So I consider that sort of stage one, really. Then we'll look at sort of stage two. So assuming they've engaged with a metabolic balance program and things are going really well, I don't advise stopping drugs immediately. I never like stopping long-term drugs immediately. And also, as an osteopath and you're a nutritionist, we are non-prescribers. So we are not legally allowed to prescribe or indeed get patients to stop drugs. So it's really critical that the clinicians liaise with the medication provider. Now, this can be a GP, can be a consultant, a specialist, but they're not stupid people. If they can see the patient is really beginning to change with some lifestyle whatever, they will definitely be willing to down-regulate the medication, which would be a brilliant thing anyway. So as long as as long as they've begun a structured metabolic plan, they're going to maintain their medication initially. They're then going to stabilize. Then we're going to see is, can we then taper down the medication?
Definitely. You've got to keep the support in place, put the new support underneath, and then you can see if it's appropriate to take the old support, like gradually away, if appropriate. I mean, that's just it's common sense, really, isn't it? You don't take the support away before you've even got anything else happening.
Exactly. And then to sort of reach phase 3, which is regulation. So really once and hopefully they're able to come off the medication, not all of them, and I'll talk about that in a second, the focus becomes glycaemic stability, lean mass building, satiety confidence, as in, they know they can go without starting to need for eating. And of course, psychological resilience. They need confidence to know that they can do without the drugs. And actually, they've now incorporated significant structural change in terms of the eating habits, really.
So really what we're sort of seeing here is MB is very complementary to these medications from your point of view.
Well, I think again, particularly in sort of phase 2s and phase 3, this is where coaching becomes critical. Because biology is only the half the story. The fear of the regained weight is often greater than the physiology itself. And I remember, lecturing on the MB weekends, I'd always say, look, most of us have some at least basic counseling skills, and those probably need to be better. But it's very often, I will say to some of my patients, I will probably get a therapist involved as well. Eating has complex psychological dynamics, and sometimes patients need to really work on those things even before they start to go on to things like the drugs or even metabolic balance. But that would be my thought anyway.
I mean, like, this is where it's always client-led as well. It's like what comes up for the client is where, if further support is needed in different areas.
It is, and the great thing I think about coaching is you've got a one-to-one contact. The patient has an expert in the background who's been through this before. They've got confidence in a metabolic balance program. They have confidence in their coach. And those things are much more likely to engineer a good outcome. I mean, even now, particularly in the NHS, they're realizing these drugs they might do the heavy lifting in the beginning, but the patient is definitely going to need additional support.
Yeah. If someone is on these medications right now, what would be your single point, like real key advice that you would give them? They're listening and they're going, well, what should I do?
When somebody says, I suppose the compatibility between, using a GLP-1 and metabolic balance. So it's an important nuance. So I don't really see this either as an either and or. So I see the pharmacology or the drugs as a scaffolding, and I see really metabolic balance as metabolic re-education. So we have the pharmacological scaffolding, but we then need the education and the structure of metabolic balance. So, there's no doubt, we've both mentioned the drugs reduce appetite, improve glycemic control. They do provide meaningful weight loss and often reducing these what we call cardiovascular risk factors. So they are legitimate and powerful tools. I think there's no dispute in that. However, they don't automatically restore metabolic flexibility, muscle mass, or long-term behavioral resilience. So I feel they can absolutely be used together. So in fact, the combination may be optimal in certain patients. So I think probably in severe insulin resistance and people with very high HbA1cs, long-standing obesities, maybe strong genetic predispositions. GLP therapies can create in an initial metabolic window, and then metabolic balance really is going to be consolidating it. So when you look at it from a strategic perspective, really, there's three possible goals. You're either going to use both long term, or you're going to use a GLP-1 short term, then transition fully to metabolic regulation, or you're going to stay on a GLP-1 at a lower maintenance dose with structured nutrition. And of course, the correct answer is it has to be patient specific. There's no, ultimate thing. It just really depends on the patient.
Couldn't agree more. And I think, because that food noise for many people is it's very, very real, and it can be incredibly challenging to overcome that. If even when you have the best sort of initial desire to say, okay, I'm going to eat healthily and I'm going to eat, if we just do metabolic balance by itself, which we know if they could dampen down the food noise, they could get great benefits on an MB plan. But I think it's such an opportunity that we potentially have to help more people. Let's use the medications for that short term, the intention, or even like you said, if they need to keep on them on low dose, but by keeping the dose as low as possible, you minimize the impact of the side effects, and it's a win-win. It's an absolute win-win.
Absolutely.
Gerry, thank you so much for all of the what you shared with us today. I think this is a really important message to get out there. First of all, that the science behind them, and just clarify some of that, and the physiology and the impact that these medications, but also just imbalance has on the body, and where we can see the dietary interventions really can play a role in changing things. So, if anybody would like to hear more, or find out more about Gerry's practice, or Gerry, you also have a podcast of your own where you share more of that, more science on you. I always find that you are endlessly curious. And you have wonderful insights into just the new things. And I mean, I think that's, as you say, 4 decades of curiosity, I think is really probably what I feel is very, very true for you.
I think what's important, because I lecture to various disciplines, and I think each profession has a danger of staying in their silo. Being collaborative and multidisciplinary is really the ultimate aim for all clinicians, to the benefit of the patient.
Yeah, basically it's having conversation and listening to the client. As metabolic balance practitioners, we personalize, and then we get the plan and we personalize it even more. That's the whole goal. Yeah. Thank you. Thank you again. Thank you so much for your very precious time. And, hopefully we could maybe even repeat this for another important topic, at some point in the future. But for now, we will say goodbye.
It's lovely talking to you, Gerry. Talk to you soon.
Yeah, take care.